Hello and welcome to another talk. Today we're going to talk about pulmonary embolism. The literal meaning of embolism is obstruction of an artery, in this case the pulmonary artery, by a blood clot. This is a simplified representation of the pulmonary circuit. Blue represents venous deoxygenated blood. You can see the IVC and the pulmonary arteries. Thrombi usually form in the deep lower extremity veins or pelvic veins, traverse up the IVC into the right atrium, right ventricle, and eventually get lodged in the pulmonary arterial system. The diagnosis of a pulmonary embolism is a radiographic diagnosis. The gold standard is pulmonary artery angiography. This has almost entirely been replaced by CT angiography, and they're ordered as a CTA chest. It's very important to order it as a PE protocol because there are other vascular systems that can be imaged within the chest, such as the aorta as well as the pulmonary veins. Here's an axial slice from a CTA chest. We can see an opacified pulmonary artery, and at the bifurcation of the main pulmonary arteries, we appreciate filling defects within the pulmonary arteries. An advantage of CT angiograms is that it can define the clot burden and the distribution of clots. This clot is considered a saddle PE, which is shown better on this graphical representation. It's important to remember that clot burden is not as important as the location of the PE. In this case, we see a saddle pulmonary embolism. A saddle pulmonary embolism is considered a central pulmonary embolism and is higher risk than a peripheral pulmonary embolism. The image on the left is a graphical representation of a main pulmonary artery PE, which would also be considered a central pulmonary embolism. The lower risk PEs are lobar, segmental, and subsegmental PEs, and these are all considered either peripheral or distal PEs. The mortality associated with peripheral or distal PEs is lower compared to the mortality with central PEs. One of the advantages of CT angiography is that it helps you evaluate for the presence of right heart strain. We're going to dive into this just a little bit, and then we're going to come back to it at the end of the talk. Here is another axial image of a CTA of the chest. You can see the right ventricle and the left ventricle, and you can see how much larger the right ventricle is than the left ventricle. Usually the LV is larger than the RV in a ratio of RV to LV 1 to 1.5. Another finding of right heart strain on a CT scan, apart from enlargement of the right ventricle, is the presence of reflux of contrast into the IVC. Both a high RV to LV ratio and the presence of reflux of contrast into the IVC on CT angiography are signs of right heart strain. It is important to evaluate this with echocardiography as well, and we're going to talk more about this later. The problem with CT angiography is the need to use iodinated contrast to be able to see filling defects. Iodinated contrast can cause contrast-induced nephropathy, and so there's caution to be used in patients with chronic kidney disease or those who have acute kidney injury. An alternative to this is a ventilation perfusion scan or a VQ scan. VQ scans rely on comparing ventilation and perfusion images to evaluate for perfusion defects. It has less diagnostic accuracy than a CT angiogram in an acute PE. VQ scans definitely play a role in the diagnosis of chronic PEs. Here are a few representative images from a VQ scan that show bilateral perfusion defects. You could consider combining data from a VQ scan and lower extremity Dopplers to potentially try to increase your diagnostic accuracy in a situation where you are unable to perform CT angiography. The ultrasound image on the right shows the left femoral vein with both compression and without compression, and we can see the non-compressibility of that left femoral vein. Let's jump back out of radiology and let's talk about some signs and symptoms of a PE. There are various symptoms of a pulmonary embolism, and as you can see, most of them are very nonspecific. One symptom to worry about is syncope. Syncope is considered a very high-risk feature in pulmonary embolism. A sudden onset of any of these symptoms should raise suspicion for a pulmonary embolism. The signs of a PE are listed below, although are also nonspecific. One worrisome sign is hypotension. Hypotension in a patient with a pulmonary embolism is a very high-risk feature and should sound alarms. The next few mentioned are actually signs of a deep vein thrombosis. These can happen concurrently with a pulmonary embolism. I would recommend for you to go look up Hohmann's sign. And that brings up, should every patient who has these symptoms be scanned for a pulmonary embolism? This is where the Wells criteria helps us. The Wells criteria are a set of criteria with points associated to them, and it can help you figure out the pretest probability of a patient having a pulmonary embolism. This criteria can help you figure out whether you should scan your patient for a PE or whether you should hold off and look for other reasons why a patient may have those signs or symptoms. One clear limitation of the Wells criteria is that the first two criteria that are highlighted are both very subjective and also carry the highest scores, and this can be a source of variation in scores between observers. Score aggregates from the Wells criteria are grouped into low, intermediate, or high risk. It's very important to note that this declares the pretest probability, not the mortality of a patient who may have a PE. Moving on to the risk factors and why this is important. Two of the most common modifiable risk factors for pulmonary emboli are obesity and smoking. The other listed in red are also risk factors, but are also implicated in provoked pulmonary emboli. It's very important to keep these in context, as this would change treatment duration with anticoagulation for these patients. I mentioned illness as one of the risk factors for provoked PE. Do not forget that we're still at the tail end of this pandemic for COVID-19, and COVID-19 is definitely a risk factor that increases your chances of having a pulmonary embolism. A pulmonary embolism in the absence of these risk factors would be considered unprovoked and would potentially need lifelong anticoagulation. This is the reason why it's important to differentiate provoked from unprovoked pulmonary embolism. Now on to the most important part of this talk, risk stratification. It is important to perform risk stratification in pulmonary embolism, both for prognostication and mortality, but also the treatment algorithm would change significantly. Risk stratification in pulmonary embolism is based on the following criteria, and we're going to talk about each of these briefly. An elevated troponin or beta-natriuretic peptide, or BNP, are considered high-risk biomarkers in patients with pulmonary emboli. They could potentially signify a high-risk PE and should be checked in patients with central PEs. Next, let's go to right heart strain. We talked a little bit about right heart strain previously. The two modalities that we can use to assess right heart strain are CT angiography of the chest and echocardiography. Recapping the two CTA findings that we saw previously, one was increased RV to LV ratio, and the second was the presence of reflexive contrast into the inferior vena cava. These are both considered signs of right heart strain, and ideally should be further investigated with echocardiography. I would encourage you to perform bedside echocardiography on all patients with pulmonary emboli who are admitted to the ICU. Echocardiography is able to elucidate RV strain better. Here we see an apical four-chamber view. The RV and LV are labeled. You can appreciate how much larger the size of the right ventricle is when it's compared to the left ventricle. The similar size ratio that we talked about in CT scans of RV to LV 1 to 1.5 should also be maintained on echocardiography. You should also note the septum bouncing towards the left ventricle. This is a sign of volume pressure overload in the right ventricle. The signs of RV enlargement as well as septal bounce towards the left ventricle are signs of right heart strain. And now moving on to the most important parameter, hemodynamics. Hemodynamic instability is defined as a systolic blood pressure less than 90 millimeters of mercury for 15 minutes or greater. It's important to note that syncope can also be considered a sign of hemodynamic instability. Now let's go ahead and define a low-risk PE. A low-risk PE has normal biomarkers, no right heart strain, and normal hemodynamics. These patients can be treated with anticoagulation alone, with or without a hospital admission. In patients who you cannot anticoagulate due to various reasons, you may consider an IVC filter. Intermediate risk PEs may or may not have elevated biomarkers, but the hallmark of intermediate risk PE is the presence of right heart strain without the presence of hemodynamic instability. It's important to note that there's no clear guideline on how to manage patients with intermediate risk PEs. It is clear that you should start anticoagulation in these patients, and you could consider catheter-directed thrombolysis or thrombectomy in select patients. Catheter-directed thrombolysis is performed by infusing thrombolytics very slowly via a specially placed PA catheter with ultrasound on its tips. Mechanical thrombectomy is another consideration, and usually chosen over catheter-directed thrombolysis at the discretion of the proceduralist. It's important to keep in mind that if these patients do develop hypotension, they will progress from an intermediate risk PE to a high risk PE, and their treatment algorithm should change. And lastly, high-risk PE. These are the patients who have the highest mortality. These patients have elevated biomarkers, right heart strain on imaging, either CT scans or echocardiograms, and the presence of hemodynamic instability. These patients will need stabilization of their hemodynamic instability and potentially systemic thrombolysis. You could use half-dose TPA per the PITO trial or full-dose TPA. Thrombectomy could be a consideration in these patients who may not be good candidates for TPA. It's very important to remember to start anticoagulation after TPA has infused. This is different from strokes, where we do not do any anticoagulation for 24 hours after a patient has received TPA. I would encourage you to go look up the PITO trial published in the New England Journal of Medicine in 2014. I've included a link in the description below. And this brings us to the end of this video. Please do hit the like button if this video was helpful to you. Leave comments for feedback or for requesting new videos. And please do subscribe to this channel. Thank you.